Gracias, Doc. Si te parece, Carlos, presentamos al siguiente expositor, el doctor Gyula Gall, neuroradiólogo intervencionista de la Odense University Hospital de Dinamarca. El profesor siempre ha estado a la vanguardia y es uno de los profesores más destacados de la neuroradiología intervencionista de Europa. Si te parece, Carlos, en el día de la fecha va a estar presentando el doctor Gyula Gall, la utilización de nuevos dispositivos intrasaculares para el tratamiento de aneurismas cerebrales. Gyula, are you online?
Yes, many thanks for the invitation. Can you see my screen?
Yes, Professor.
Okay, so I've seen that we are 25 minutes late. So
we're a little
even
bit
in
late.
Buenos Aires, so I try to make it quick. So
Please,
thank you very much for the invitation, and pass over my greetings to Pedro and all my friends. I see you too, but all the other ones also. So I will talk about these two devices, the NextStent and Contour, and let's jump on it. I'm a consultant for a company producing these devices. These are braided nitinol mesh discs. We put them inside the aneurysm at the neck, and through an O27 microcatheter, both are retrievable, repositionable, and electrically detachable.
Professor, could you share your screen, please? We're not able to see it.
Sorry, this is what I asked you, but let me see how I should...
Stop the sharing and share it again, please.
Share screen, yes. Can you see?
No, not yet, Professor.
Not yet. So I click on share screen.
Yes, please.
I do. Window that you want to, okay, this one.
Yeah.
So is it okay now?
Not yet.
Wow. So select a window or an application that you want to share, and I selected this.
Okay, we're trying to fix it. Maybe if you could stop the sharing and start the sharing again, maybe it will work.
Professor Gyula, meanwhile, what we can do. Okay, here we go. Now we got it. Now we got you.
Is it okay now?
Yeah, perfect.
So select the window or an application that you want to share. You can see it now.
Yes. Okay, we're trying to fix it. Maybe if you could stop the sharing
I just
and
told
start
you
the
this
sharing again, maybe it will work.
Detachable, blah, blah, blah. So the Contour works on its own.
Professor Gyula, meanwhile,
the mesh is very tight,
we can do.
And it goes thrombosis in the sac. The NextStent, is it okay now?
Yeah, perfect.
So the NextStent is a little bit less tight. You can see it now. We can go through. So the mesh, at the side of the mesh with another. A very short video. Please look at this if it works. Yes, come in. So you will be able to see how we deliver and how they act, these devices. It just takes 2 minutes. This is a 27 catheter. This is the contour device. Summary. The device is
important for us, and they are very useful tools for the treatment of brain aneurysms. We're going to have a very small change in the program. Martin Gunis will be the next speaker. Pedro, could you please present him? The field. Dr. Linick, do you have any more comments?
Unfortunately, Matthew, we are running a little bit out of time. So I see a lot of questions for you coming from the sea. So we will send the
LV, a low viscosity liquid embolic. As a disclosure, I'm employed by Microvention. The Scepter Mini is indicated for neurovascular use for the infusion of diagnostic agents such as contrast media and therapeutic agents such as embolization materials that have been approved or cleared for use in the neurovasculature and are compatible with the inner diameter of the Scepter Mini balloon catheter. It is not intended for embolectomy or angioplasty procedures, for use in the coronary vessels, or for use in pediatric or neonatal cases. The unique features of the Scepter Mini are its self-sealing balloon and leak-proofing prepping, its low profile, its trackability and compatibility with 0.08-inch guide wire, its soft coaxial balloon system, and 700 psi rated working lumen. On this slide, I will demonstrate the differences between the Scepter Mini and its larger cousins, the Scepter C and Scepter XC. Notice the longer working length, the shorter ID, the smaller ID, the smaller distal OD, a smaller balloon at 2.2 millimeters with a range of 1.7 to 2.7, shorter balloon, shorter distal tip length. Notice that the prep is with a 1 cc syringe rather than a 10 cc syringe with 100% contrast material. And for clinical use during the procedure, the balloon is operated with a 1/4 cc syringe. The distal 10 centimeter stiffness of the Scepter Mini is very comparable to that of the Headway Duo. And both of these are slightly stiffer than the Marathon 1.5 French. It is important to hydrate the balloon for 30 seconds or more before it is inflated. Otherwise, it may crack. As I mentioned, we recommend 100% contrast material for better visibility of the balloon under fluoroscopy. Using Omnibake 300, the deflation time never exceeds 15 seconds. In my personal experience, it is more like 6 to 7 seconds. For prepping, the operator preps the device more or less the same way he or she would prep the Scepter C or XC by holding the attached syringe to the hub of the microcatheter in a vertical position, holding the tip of the microcatheter balloon in a vertical position. With a 1 cc syringe, contrast is injected to purge the air through the system and the balloon. When the contrast reaches the purge hole, the system is prepped. At that point, the operator swaps the 1 cc syringe for a 1/4 cc syringe for clinical use. In this case, courtesy of Dr. Almeida from Cartagena, Colombia, notice the ability of the Scepter Mini to track through this tortuous superficial temporal artery that feeds this scalp AVM. During the development phase of the catheter, we tested it in this silicone vascular model. On the next fluoro sequences, I am the one manipulating the Scepter Mini and a 0.08 inch guide wire. And I'll be using two techniques here, either leading with the guide wire and following with the microcatheter, or alternatively, pushing both the guide wire and the catheter together with the guide wire leading. On this sequence, notice the 180-degree loop. And even though the wire is quite soft, passing the Scepter Mini over the wire does not herniate the system into the other branch. And again, here we're pushing both the wire and the catheter together. We're going more distally, this time leading with the wire. Advancing the scepter over the wire and then advancing both together. And at this point, the system is quite trackable. However, at this particular point, you will notice movement of the model. And that is because I'm having to push somewhat harder. So after all these tortuosities, we've sort of reached the end of the ability of the system to track well. So we're now in final position. And on this slide, we demonstrate inflation of the balloon, which takes place over 2 to 3 seconds, followed by deflation of the balloon, which will take about 5 or 6 seconds. There are 4 publications on Scepter Mini, 1 preclinical and 3 clinical. In this preclinical study, Dr. Molenbroek and his studies compared the Scepter Mini to a regular 1.6 French microcatheter using fill as an embolic agent and the pig reti mirabile. They found that the total procedure time was significantly shorter using Scepter Mini. The number of reflux events was significantly lower, none versus 9 using Scepter Mini, and that the embolization extent was significantly higher. In this first multi-center clinical experience, 7 European centers described their experience using 34 Scepter Minis in 20 patients. 80% of these patients were cerebral AVMs using the microcatheter under 4 different clinical circumstances that I will outline in the following slide. The mean diameter of the blood vessels in which the Scepter Mini was inflated was 1.9 millimeters. The navigability of the Scepter Mini was rated as easy or very easy in 88% of the cases. There were technical failures in 4 out of 23 of the embolization procedures, and they were all related to insufficient stability of the balloon within the vessel. No complications related to the Scepter Mini were observed. On this slide, I summarized the 4 clinical circumstances under which the Scepter Mini was used in this report. A, liquid embolic material injection. B, proximal flow arrest for liquid embolic material injection through a more distally placed second microcatheter. C, occlusive selective angiography. And finally, D, using the Scepter Mini as a bounce-off device to catheterize an acutely angled second branch, what I call the bounce-off technique. In this demonstration of the multi-plug technique, Dr. Sachi and Sakurji were able to cure this brain AVM using a combination of 2 very distally positioned Scepter Minis and a 1.6 French regular microcatheter. Notice all the tortuosity that the Scepter Minis were able to negotiate. In this case, using the bounce-off technique, this acutely angled feeder to the superior cerebellar AVM was catheterized by inflating the Scepter Mini distal to the takeoff of the vessel and bouncing off a second microcatheter and wire off the Scepter Mini. In this report, Dr. Haidt and his colleagues from Stanford reported curing 2 patients with anterior cranial fossa dural fistulas fed by the ophthalmic artery by a single onyx injection. Here is one of the 2 patients, a patient with Cowden syndrome and multiple dural fistulas. On this internal carotid injection, we see the ophthalmic artery feeding the dural fistula of the anterior cranial fossa, and a more proximal branch reaching through the orbit to feed a scalp scalp AVM that was not targeted for the embolization because it's benign. On this non-subtracted image, we see the distal position of the Scepter Mini that was achieved, as well as a superselective angiogram of the dural fistula. This is the cast of onyx that was obtained, and a postoperative angiogram showing cure of the dural fistula and persistence of the non-targeted scalp AVM. Finally, in this publication, Dr. Jagadisan and his colleagues from Minneapolis described their experience in delivering through the Scepter Mini liquid embolic in 6 patients, adjunctive support for delivery or positioning of the web device in 2, and finally, post-deployment repositioning of a web device in 1 case. These 4 frames show examples of distal catheterization of brain AVM feeders using the Scepter Mini. Again, notice the ability of the Scepter Mini to negotiate all these curves within the cerebral vasculature. Let's turn our attention to fill LV. As you know, fill is opacified with covalently bound iodine, which does not leach over time. Therefore, there is no tantalum. And the advantages of this is that it minimizes streak artifact during control imaging, as seen over here on the right, fill and onyx. There is no tattoo effect from the tantalum powder when the material is injected into a skin lesion. There's no tantalum aggregation, which can either plug the catheter or lead to catheter rupture. And fill is compatible with cautery, with no sparking at the time of surgical resection. Fill is supplied in ready-to-use syringes that do not require shaking or pre-procedure loading. It provides homogeneous radiopacity, as demonstrated on the right, and the radiopacity is less than onyx. Fill LV is recommended for reaching distal vessels and penetrating deeper into the malformations. It should be used because of its low viscosity with a flow arrest technique, such as scepter balloon, pressure cooker, or a higher viscosity plug made with a higher viscosity liquid embolic agent. Compared to Fill 25, Fill LV has the same chemical components. However, it achieves its lower viscosity not by dilution by DMSO, but rather by using shorter polymer chains. Its viscosity is 12 centistokes, comparable to SCID 12, whereas Fill 25 has 16 centistokes and Fill 35, 36. And that compares to Onyx 18 and 34. It has the same radiopacity, similar embolic capacity to Fill 25, and equivalent precipitation characteristics. Whereas Fill 25 achieves its lower viscosity by increasing the amount of DMSO in relationship to the polymer, therefore diluting the polymer, Fill LV has the same amount of polymer as Fill 25, but is less viscous. And the reason for this, as I mentioned, is that shorter polymer chains were utilized. Since Fill LV liquid embolic is not diluted with DMSO to achieve a lower viscosity, it has a 56% more embolic capacity than SCID 12. This results in less DMSO injected and potentially for shorter procedure times. In this image in the pig rete mirabile, we see superior distal penetration when looking at Fill LV on the right compared to Fill 25 on the left. These images were courtesy of the UCLA Research Lab and Professor Moon-Hee Han. A universal adapter also comes packaged with Fill. This device acts essentially as a bridge that bypasses the hub of the microcatheter. So this little peg extends from the adapter to the apex of the hub. It is compatible with any DMSO compatible microcatheter. It avoids mixing and dilution of the fill liquid embolic in the hub of the DMSO filled microcatheter and reduces the dead space of the microcatheter, therefore saving up to 20% from the first fill liquid embolic syringe. Two publications are found concerning preclinical evaluation of Fill LV. In this first publication, Dr. Samaniego and his colleagues evaluated Fill LV and compared it to SCID 12 in a setting of balloon occlusion with a scepter and a regular microcatheter. They found that occlusion ability, on-off injection, and ease to retrieve the microcatheter and balloon with Fill LV were optimal. Fluoroscopic visualization of Fill LV was adequate to optimal. Average embolization times with flow arrest was substantially shorter with the microcatheter plugging compared to balloon, the balloon being shorter. Embolizations with Fill LV required less volume and were also shorter when compared to SCID 12. Finally, histologically, they found minimal inflammatory changes related to the embolic material and permanent occlusion at 90 days. In this publication by Dr. Mullengroup and his group, they compared FIL-LV to FIL-25 and SQUID-12. They found that the embolization extent was not significantly different among the three investigated agents. However, there was a tendency towards a higher embolization extent for FIL-LV. The amount of reflux was significantly lower for FIL-LV and SQUID-12 compared to the standard FIL-25. I'll finish with a case courtesy of Dr. Nachi Kosher. It is a tentorial dural fistula fed by the meningo-hypophyseal trunk. And on these 4 screen grabs during deposition of the FIL-LV, we see different configurations of the FIL-LV permeating the nidus of the fistula, and the embolization resulted in complete cure of the lesion. Notice on the post-procedure expert CT, the complete absence of artifacts related to the embolic material and the exquisite depiction of the FIL-LV within the nidus of the fistula. In his usage of the Scepter Mini, Dr. Mullenbrook concluded that trackability and navigability of the Scepter Mini were comparable to the Headway Duo or Apollo. Flow control with the Scepter Mini provided better understanding of the vascular anatomy of the target, more controlled embolization, higher embolization extent, but that proximal reflux or movement of the balloon could occur, especially when the vessel diameter was more than 1.9 millimeters. He also found and warned that turning the stopcock handle can actually inflate the balloon. And this is related to the fact that the inflation volumes of the balloon are so low. Remember in that slide that I showed earlier, the nominal inflation volume was 0.02 milliliters. In his usage of FIL-LV, Dr. Mullenbrook found that it provided better distal penetration. Plug formation was either difficult or impossible, and recommended that the plug be formed with FIL-25 or a higher liquid embolic material, a pressure cooker technique, or alternatively, a balloon like the Scepter Mini or the Scepter X or XC. So in summary, the combination of Mini Scepter and FIL-LV allows for very distal catheterization and tortuous neurovasculature, flow control, and improved distal embolic material penetration. With large volumes, it's easier to see through FIL than other tantalum opacified liquid embolic agents. Metallic artifacts from tantalum powder are eliminated, greatly improving subsequent CT imaging. Thank you for your attention.
Well, thank you very much, Jack. It was an impressive presentation. We are looking forward to try the combination. I think it's a fantastic tool for distal occlusion of AVM that has show us and teach us Saru yesterday. I think it's a tool, it's a very valuable tool. So I thank you. Unfortunately, we don't have that much time for questions. I will send you, I have at least, can see now 10 questions. So I will send you right away by mail. I hope you will answer directly to the audience. Thank you again. Muchas gracias.
Thank you, Pedro, for having me. Hi, everybody.
So let's go. I think we have some presentation in front of us. So let's go, guys. And I don't know who's going to present Clarenson.
Sí.
Maybe some of you.
Tengo el gusto de presentar a un amigo, el doctor Frédéric Clarenson, profesor de la Universidad de la Sorbona, jefe del Departamento de Neuroradiología Intervencionista del Hospital de Petit-Salpêtrière en París, quien tiene muchísima experiencia en la embolización de hematomas subdurales. No sé si lo tenemos en línea. Bonjour, Fred. Ça va bien?
Hi. Bonjour, Ivan. Hi, everybody. Good afternoon. Good morning.
Hi. Good morning.
Thank you for the kind invitation, and thank you for the organizing committee for inviting me to this lecture. So I will talk to you about embolization of chronic subdual hematoma and share with you our experience in my center. Oh, sorry. I will try to share my screen. Okay. Let's go. So you know that the chronic subdural hematoma are very frequent. The annual incidence is 2 to 20 person per 100,000 inhabitants, and this incidence is decreasing with the aging. So elderly patients are more prone to have a chronic subdural hematoma, and this incidence is also increasing due to the fact that a lot of patients are treated by anticoagulation or antiplatelet therapy. So it's a very frequent disease, this chronic subdural hematoma. There are now a lot of evidences on the implication of the middle meningeal artery in the pathophysiology of this chronic subdural hematoma. When you do an angiogram of the middle meningeal artery in a patient with a chronic subdural hematoma, you often see this blush, this capillary blush, which is a surrogate marker of the hyperemia of the dura mater in the patient with a chronic subdural hematoma. Additionally, when you look at the caliber of the middle meningeal artery ipsilateral to the chronic subdural hematoma, you often see that this middle meningeal artery has an increased caliber. So when you compare the caliber of the middle meningeal artery ipsilateral to the hematoma, it's much more larger compared to the contralateral side. And when you compare the caliber of middle meningeal artery in patient with chronic subdural hematoma versus control, the diameter is also larger in this study. Focused on 3D TOF MR angiography. And we also my group published this series on the caliber of the middle meningeal artery in CT angiography, and we had the same result. We have a bigger caliber of the middle meningeal artery ipsilateral to the chronic subdural hematoma. Additionally, when you do a CBCT after the embolization of chronic subdural hematoma, you often have this enhancement of the membrane of the chronic subdural hematoma, which is also a surrogate marker of an hyperemia of the membrane of this chronic subdural hematoma. So the pathophysiology of the chronic subdural hematoma is complex. It's implicating angiogenetic factor. It's implicating inflammatory process with neutrophils, interleukin, and also fibrinolysis. So there is like a vicious cycle, including the external membrane of the chronic subdural hematoma, which will be responsible for repeated bleeding inside the subdural hematoma, and which will explain the recurrence of this bleeding. So all this pathophysiology is the rationale to embolize this chronic subdural hematoma through the middle meningeal artery. And the first case series focused on this technique, embolization of the MMA in chronic subdural hematoma, has been published in 2017 by a group, by Ban et al., a group from South Korea. And it was a monocentric retrospective non-randomized study, including about 70 patients, and they compared this patient who were embolized through the middle meningeal artery versus an historical cohort of patients with chronic subdural hematoma, but who were not embolized. So they included only adult patients, and they excluded patients with a small chronic subdural hematoma or without a mass effect. And the clinical protocol was embolization first in asymptomatic patient, and in symptomatic patient with a deficit, they perform surgery first and then embolization to prevent the recurrence of the bleeding. And the primary endpoint of this study was a composite endpoint. It was the treatment failure, which was either an incomplete resolution of the chronic subdural hematoma, or the need for a surgical rescue, or a recurrence of the chronic subdural hematoma. So they compare the embolization group, 72 patients, versus the historical cohort. So you can see that the treatment failure was observed in only 1.4% of the cases in embolized patients, versus more than 27% of the cases in the control group. So a lower rate of failure treatment in the embolization group. And when we look at the subgroup analysis, you can see that the embolization was favorable in all cases, even in patients with no removal. Even when we compare small hematoma versus big hematoma, even when we compare asymptomatic hematoma versus symptomatic hematoma, and even when we compare unilateral versus bilateral hematoma. So all the patients treated by embolization benefited from this embolization. So recently we published our series, our experience in JNIS, so our experience in embolization of the middle meningeal artery to prevent the recurrence of bleeding in patients with chronic subdural hematoma with a high risk of recurrence. So we perform embolization after the surgery to prevent the recurrence in patients who already had a recurrent chronic subdural hematoma or in patients who were at risk to have a recurrence. It was patients who had antiplatelet therapy, anticoagulation therapy, coagulation disorder, or hepatopathy or chronic alcoholism. And we compared this more than 100 chronic subdural hematoma embolized in 89 patients. We compared this patient to a control group, an historical cohort with more than 200 chronic subdural hematoma, which were only treated surgically without post-surgical embolization. And here you can see the comparison between the embolization group and the control group. So the recurrence in the embolization group was observed in only 4% of the cases versus 14% of the cases in the control group, in the patients who were not embolized after the surgery. So there is a benefit, obviously, in this series to embolize post-surgically the chronic subdural hematoma. So the question we could ask is, which embolic agent should we use in this embolization of chronic subdural hematoma? Microparticles, liquid embolic agent, and the other issue may be the access. We will see that it's often very old patient, and sometimes the access could be an issue. So in our series, we almost embolize only patients with microparticles. So what is the rationale? It's very simple. We are doing it for many years for the embolization of pre-surgical embolization of meningioma, for instance. It's very safe. In good hands, it's very safe. There is almost no risk. It's very quick, and we have a distal penetration. The drawbacks of the embolization with microparticles is that you should use a large bore microcatheter. It could sometimes be difficult to navigate this microcatheter. There is a risk with the dangerous anastomosis, and the occlusion is usually not definitive. It's a temporary occlusion. When we look at the literature, it's a systematic review of the literature on the embolization of chronic subdural hematoma through the middle meningeal artery. We see that in most of the series, the embolization was performed using microparticles. And in a very few series, NBCA was used. And there is no large series using EVOH for embolization of chronic subdural hematoma. And when we look at the three biggest series on embolization of the MMA in chronic subdural hematoma, you see the series of Ban et al., another series with 60 chronic subdural hematoma, and our series. In almost all the series, the patients were embolized with microparticles. So the literature, there are a lot of evidences in the literature of the safety of using a microparticle with no complication in this series with embolization with microparticles. We know that embolization with microparticles should be performed with a free flow injection in order to avoid reflux and in order to avoid the opening of this dangerous anastomosis. We know from our experience with the embolization, the pre-surgical embolization of the meningioma, that there are some risks when we you don't respect the safety rules. There are some risk of complication with embolization with microparticle. In this series that we published a couple of years ago, the complication rate in embolization of meningioma, pre-surgical embolization of meningioma, was 1.5%. So for instance, this patient who was embolized for this meningioma through the middle meningeal artery, the embolization was, the microcatheter was too distal, it was in wedge microcatheter, and the operator didn't see the anastomosis through the meningioma with the posterior meningeal artery. The embolization was performed with microparticle. The patient had, after the embolization, a cerebellar syndrome and a cortical blindness with this acute ischemic stroke, which was due to the migration of the microparticles through the tumor towards the posterior meningeal artery and towards the vestibulobasilar system. So you have to be very careful when you use microparticles to avoid this dangerous anastomosis. The other drawback with the particle is there is often a delayed recanalization. The occlusion is not definitive using microparticles. And it may explain what we see in this Kaplan-Meier curves. In our embolization group, the recurrence was very late. The recurrence occurred about 50 days after the embolization. So maybe there is a delayed recanalization, which may explain this delayed recurrence in the embolization group. Another issue is the access. So in these patients with chronic subdural hematoma, they are often old patients. The average age of the patient included in our study was 74 years. It's much more higher compared to patients with mechanical thrombectomy. In meta-analysis, it was 68 years. So we are facing very old patients with tortuous vessels, with atheroma, and you will have some type 3 aortic arch and bovine arch. So here you have some CT angiography of the supraaortic trunks with the ugly supraaortic trunks, with here a bovine arch, here a very tight loop at the origin of the left common carotid artery, and here a very tight loop at the origin of the right common carotid artery. So it could be very, very difficult to catheterize this supraaortic trunk. So in our experience, what we recommend is to systematically perform a supraaortic CT angiography, supraaortic trunk CT angiography, before the embolization of the chronic subdural hematoma to depict a type 3 aortic arch, to depict the loop at the origin of the common carotid artery, to depict a bovine arch, to depict severe atheroma, and also to look at the agenesis of the foramen spinosum, which is a surrogate marker of MMA arising from the ophthalmic artery, which would contraindicate the embolization. So the potential of the radial access is very interesting because it may be helpful when we have a bovine arch, when you have loops at the origin of the right common carotid artery. It would also help to reduce the risk of severe growing puncture complication. And it is noteworthy that in the series we published in JNIS, we had one case of death secondary to a femoral artery dissection, which eventually led to the death of the patient. So what we do now is what we call the tailored access. So we don't use radial access as first line systematically. Why? Because sometimes radial access may be more difficult than femoral access, especially when you want to go to the left external carotid artery. So what we do, we perform CT angiography before the embolization. And what we see, it's here from our experience, we compared in the period 1, the femoral access only as first line in 43 patients. We had a failure rate of 10%. And we compared the second period in which we used the tailored access based on the CT angiography findings in 95 patients. And we only had 1% of complication. So we choose the best way to embolize based on the finding of the CT angiography, either radial access or femoral access, depending on the anatomy of the supraaortic trunk.
Okay, let me call
so
you.
Here an example, an 82-year-old male with this right chronic subdural hematoma, which has been treated surgically, evacuated surgically. And here you have the CT angiography of the supraaortic trunk. So you can see that the origin of the right common carotid artery.
Where are you at now? Where are you at now? Well, wait, Billy. Wait, tell me what happened again. Okay. Were you alone? Billy, were you alone? Okay, so you were driving on 95? Oh, okay. Did you almost get in an accident? Did you drive okay? Oh, okay. 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 Yeah, Billy, go to the hospital. Go to the hospital. Have them check it out. Have them check it out. Okay, it's probably nothing. It's probably nothing, but you don't want to fuck around with the eye, the detached retinas and stuff like that. I mean, you need to have your eye. This may be separate from all your other problems. You know, we're going to have more the older we get, but have it checked out. Have it. No, Billy, it's probably nothing, but you don't want to fuck around with the eye. You don't want to fuck around. Just go to the hospital, have them check and say you're fine, and then you're okay. So, yeah. Have them call the ophthalmologist so they know you're coming, and and have be checked out. Probably Jimmy has influence. Have a fucking eye doctor see you. Don't fuck around with an ER guy. He's like me. He sees when he sees a problem, he sends it away. So have Jimmy have you see an ophthalmologist. He can make a few phone calls, and I'm sure. That's not a bad idea. That might help. Are you good friends with him? Give his office a call. Hey, good idea, Billy. Give his office a call. Explain to her what happened. Say your brother advised me to go to the hospital. What do you think I should do? And that way he might say, yeah, I'll tell you what, go to the hospital and I'll meet you down there or something like that. Yeah, do that. To tell us, secretaries know what's going on. I mean, if she's there, she'll tell you. But tell her you're going to the hospital. I mean, you got a problem, you want it solved. You don't want to take, oh yeah, don't worry about it, come back tomorrow. Fuck that. Okay. Give me a call. Yep. Don't fuck around with your eye. Go. Evolution of the therapeutics.
There is the modification of the body has to develop inflammatory response to start healing. And then you can add a pro-inflammatory modulator or anti. The drug-eluted stents, which is the one which is used mostly within with our cardiovascular colleagues. The drug-eluting stent act only in the intima proliferation, but doesn't